I'd like to share a few cases where iFR co-registration has changed my practice. The first case is of a 65-year-old gentleman with exertional chest pain and a positive exercise test. He had a coronary angiogram, which is highlighted here. The left system was unobstructed. On the screen you can see the right coronary artery, which has moderate proximal disease with further severe distal disease leading into the PLV and PDA branch. We were unclear whether or not we wanted to treat the proximal segment of this vessel, but were very clear in our minds by looking at the angiogram that we had to treat the distal lesion from the main branch into the PLV. In order to guide our intervention, as we routinely do at the Hammersmith, we used iFR co-registration. We passed the iFR wire down to the distal vessel, and we found that the iFR in the PLV branch was in fact 0.93. This was obviously very surprising, and suggests that neither of the two lesions that we'd interrogated on this assessment were flow limiting. However, clearly the patient had symptoms of angina, and he had a positive exercise test. You will note on this still on the image that there is a significant lesion in what appears to be a small PDA vessel. We therefore took the opportunity to pass the iFR wire into this small PDA vessel. What you can see here is a significant iFR value of 0.21. So rather than stenting from the main vessel into the PDA, our approach to this patient's coronary anatomy and intervention was now to be stenting from the main vessel into the PDA vessel. The procedure was performed using two wires, and I won't bore you with the technical details. However, prior to performing the procedure, we tried to identify where most of the hemodynamic pressure loss was, and you can see here on this pullback very clearly that the pressure loss was in the focal area. When we used iFR co-registration, furthermore, we found that all the pressure loss was associated with that severe osteal lesion into the PDA. As I said, the procedure was done using standard techniques. A provisional stent was placed from the main vessel into the PDA with balloon dilatation at the end to open up the stent struts into the PLV branch. In order to ensure good hemodynamic result from our intervention, we repeated the hemodynamics and iFR assessment. When we passed the iFR wire into the PDA vessel, as you can see here, we can see an iFR value of 0.96, suggesting complete resolution of the hemodynamic loss from the osteal stenosis. Furthermore, it also allowed us to determine that the proximal lesion was actually not hemodynamically significant. So in summary, iFR co-registration here has completely changed our approach to intervention in this gentleman's right coronary artery, and really is an example of how iFR co-registration is not only guiding us onto which vessels and which lesions to intervene, but also how to intervene in daily interventional practice.